Hello there. Welcome to Cross Section. I'm Paul Rutkowski. Dr. Elizabeth Ann Frost is with us today. Doctor, welcome to Cross Section.
Thank you.
Wonderful to have you with us.
Thank you.
Dr. Frost is the chairman of anesthesia at New York Medical College right here in Westchester County. She's been featured in many publications, as well as she's written 15 books. And she is the editor of the Trauma Anesthesia newsletter, the International Trauma Anesthesia newsletter. She's a very busy person, and it's wonderful to have you here. I understand that there are only 3 women who chair anesthesia programs in this country. Is that true?
That's true, yes. There's a very, very important, impressive lady by the name of Dr. Willocks in Boston, Dr. Mary Jane Majesco in Baltimore, and I'm the 3rd here in New York State.
Dr. Frost, why anesthesia? Why did you go into anesthesia?
Well, I have to admit that wasn't my first choice. As a matter of fact, I started out going to be a surgeon. But I found that in surgery, I didn't seem to be curing people, but rather cutting things out. Then I tried medicine. In medicine, I found I was talking and talking and talking and always quoting the New England Journal, the Lancet. I tried pediatrics, but frankly, I felt that with pediatrics, I was just a little bit soft in terms of taking care of children. Often I couldn't be truly objective. So then I began to think, which specialty in medicine really does what it says it's going to do? The anesthesiologist says, I will take away your pain. And sure enough, the anesthesiologist takes away your pain. I find it to be a very reliable and a very exciting specialty. We can take a patient from being, as you are, completely intact, talking, walking, to almost to the point of death, and bring them back again. That's the critical point. It certainly is an exciting specialty, particularly today.
Some people say I walk around in a perpetual coma anyway. But now anesthesia started out in very crude forms, didn't it? And it was a very risky business 100 years ago.
It most certainly was a very risky business. In fact, it started out from a very near death. Anesthesia had its beginnings in medical students experimenting with drugs, rather as today we might find some of our students experimenting with various recreational agents. In those days it was very popular to experiment with nitrous oxide or with ether in what was called ether frolics. And there were a group of young...
Sounds like a Saturday morning TV show.
It does a bit, doesn't it? Well, there were a group of students who had got together in a small town called Jefferson in Georgia. And they were having a lot of fun with experimenting with ether, dropping ether on themselves, laughing, having a lot of fun, just behaving generally like young teenagers are prone to do. Well, what happened was there was a small black boy who was watching their antics, and he wanted to get involved with what these white upper-class kids were doing. And these white kids thought they would teach him a lesson. So they grabbed the boy, they held him down, they poured the ether on top of him, and he became completely comatose. They were terrified. There was going to be a race riot in the front. They had, in the south, they had killed this child, so they were all ready to run away. And one of them said, why don't we call the local doctor and see if we can do anything? Well, they did, and shortly after that, one of this group said, you know, I've had this lump on the back of my neck for a long time. Do you think you could take it out? And they remembered what had happened with this boy. So they said, let's try it with some ether, see if we can put you to sleep, take away the pain, do this operation. Sure enough, March 30th, 1842, Crawford Long in Jefferson, Georgia, was able to anesthetize this young colleague of his safely, or relatively safely at that time, but certainly pain-free. And from that came the beginnings of anesthesia.
Do we still use ether today?
No, we don't. It was a very, very good agent in the beginning, a relatively safe agent. However, of course, as you know, it explodes. Many of the things we use in the operating room today, such as the cautery, require a light, require high heat. The danger of explosion is there, so ether is no longer permitted to be used in the United States.
All right. What do you give and when? How do you determine with a patient? First, you make a pre-assessment, true?
Yes, we do.
In terms of the patient's chemistry, their build, their size, their gender, whatever. How do you determine exactly how to handle a patient and what to give?
Well, you're absolutely right. It's not as though we're dealing with a suit off the rack. Everything has to be custom made. We must see the patient ahead of time. First of all, we have to find out what kind of operation is this patient going to have. The patient's going to have a simple operation, say, on the leg or below the waist, maybe a regional type of anesthetic, a spinal anesthetic might be a good idea. Obviously, if the patient's going to have a craniotomy, we can't anesthetize them just from the waist down. We're going to have to anesthetize the whole body. Then we can consider how much relaxation is required with this patient in terms of, is it a big abdominal operation? Do we have to paralyze the patient with what we call muscle relaxants? Or would this be a case such as an eye operation, a cataract operation, in which we don't have to have the whole body asleep? Can we just give the patient a little bit of sedation, a little bit of a narcotic agent, or a little bit of a relaxant? Can we use these drugs, just a little bit of this and a little bit of that, and get the effect we want? Is this patient very anxious? Are we concerned about pain control? There's a big difference between using, say, an anxiolytic and a narcotic agent to take away the pain.
What's the difference between the two?
Well, for instance, if you were very nervous but you had no pain, I might think of using a drug such as Valium, or some of the shorter-acting drugs like Valium called midazolam, Versed. Or let's say you have a broken leg and your main concern is pain, not so much the anxiety, so therefore I might want to give you a very strong narcotic agent such as fentanyl.
And you generally pass an endotracheal tube down the patient's throat in many processes?
In many instances, if we wish to control the ventilation, or if we want to have the patient completely asleep, if for some reason the surgeon is working on the head or neck, and it's important for the anesthesiologist to be away from the patient's head and neck, then we may well want to put in an endotracheal tube. An endotracheal tube is something like this. Looks a little frightening, but it is passed relatively easily and simply into the trachea. Little balloon we can blow up here so that there'll be no danger of any stomach contents coming out of the stomach and going into the lungs and causing pneumonia, which of course is a dreadful complication.
And anesthesia is entirely safe these days, isn't it? You have statistics to prove that out.
Anesthesia is very much safer than it was. That it is completely safe, I don't know if we'll ever reach absolute zero. Okay. But from the times back, shall we say in the 1850s and 1860s, when you expected perhaps even a third of patients that were anesthetized to suffer some terrible consequence, we can say now that complications related to anesthesia may occur in something like perhaps 1 in 500,000 cases directly related to anesthesia. Over the past, I would say 6 years, 7 years, anesthesia has become very, very much safer.
So maybe entirely was a bad choice of words.
Perhaps. I could tell you that crossing Martin Avenue here is relatively safe because there's not very much traffic, but then there's always some crazy driver that might come down and something awful might happen to you. But for the most part, it is very safe these days.
All right, let's set up a scenario. A patient is in the hospital bed and you visit.
Yes.
And the patient is afraid. It's always been one of my fears, and I freely discuss my fears right here on Cross Section. That's why people watch. They have nothing else to do but study my fears. Anyway, I'm afraid. I don't want to go to sleep. It's losing control.
Yes.
How do you reassure me if I'm really suffering some anxiety about it, and I tell you, doctor, I've had this before, it scares me, and I'm really frightened about losing consciousness?
I can well understand that. I feel the same thing myself. I would be, knowing quite a bit about anesthesia, I would have a great deal of difficulty in trying to select just the right anesthesiologist for myself. So I well understand I don't want to lose control either. Let's look at the alternatives. Let's say this is an operation that's going to be performed in an area that we can reasonably block with a nerve block. Operation on the arm, for instance. We can block just the nerves going to the arm. The patient will be awake. The patient is very anxious. Through an intravenous infusion, I can give a little bit of Valium, a little bit of fentanyl, so the edge is taken off things. So the patient is in control, no longer anxious. Then with a single needle stick, I can paralyze the pain sensations in that nerve to that area. Or let's say the patient is going to have a hernia operation or some leg operations, we can do a spinal anesthetic or an epidural anesthetic, in which the anesthetic is put not into the spinal cord but into the area surrounding it.
Are there times when a surgeon will say to you, I know you can use a local, but I want them out. I work better when they're out?
Sometimes surgeons will say that. What do I do about it? Consider the patient. What is best for the patient? Not what's best for the surgeon. Because sometimes the surgeon can then be talked into, look, it's going to be this way, that way. For many reasons, I think it's best that we take this type of anesthetic. After all, it's my job. I've gone to school for many, many years to learn what is the best anesthetic for this patient under the circumstances. The surgeon hasn't, and he must listen to what I'm going to say with regards to the anesthesia. I'm not going to tell him how to do the surgery. By the same token, the anesthetic is my choice.
What is the difference between an anesthesiologist and an anesthetist?
An anesthetist in this country is a nurse, somebody who has finished nursing school as a registered nurse and then has spent some specialized time in learning anesthesia. An anesthesiologist is a physician. An anesthesiologist has finished medical school, has finished an internship year, and then has spent a minimum of 3 years and often 4 years in the specialty training of anesthesiology.
Will you call the plays, give the directions, write the prescriptions, and tell the anesthetist, this is what I want you to do, and this is how much, and this is when? Or are you usually right there?
I would usually be right there. Here at Westchester, at the county centre, we do not have nurse anaesthetists. They are all anesthesiologists there. But in situations where the anesthesiologist supervises the nurse anaesthetist, usually it's done by consultation. The nurse anaesthetist and the anesthesiologist will discuss how the case is going to be managed. On a second-by-second basis, the nurse anaesthetist will frequently give the drugs, will determine how much to give, as I said, most usually under the direction of an anesthesiologist.
I'd like to remind everybody that you're watching Cross Section. I'm Paul Rutkowski. Dr. Elizabeth Ann Frost is with us. She is the chairperson, I should say, of the Department of Anesthesiology at New York Medical College right here in Westchester County. And you're also a book reviewer for the New England Journal of Medicine. You have been since 1983.
Yes.
You're a very busy person. You come to us by way of Glasgow, Scotland, and I understand that you interned over there and you took your residency in anesthesia at New York Hospital. Is it difficult for a person, more difficult to study anesthesia than any other medical field? I know you have to go, you just mentioned the requirements, but are there any difficulties that one has to be aware of?
I think it's a special type of person who becomes an anesthesiologist. There is very, very little room for mistake. If the anesthesiologist, for instance, steps on your oxygen line, within 2 to 3 minutes you're going to see very marked problems, and within 4 to 5 minutes you're going to be dead. So the anesthesiologist must be a person who is meticulous in his precision, in the way he lays out his drugs, in the way he lays out his equipment. He must be somebody who is prepared to check again and again, rather like an airline pilot in many ways. And again, anesthesia has been likened to flying a plane. Takeoff, landing, very critical, checking all your equipment, making sure everything works. It's been said of anesthesia that it's 99% boredom and 1% sheer terror. Of course, when you start out, it's 99% terror and 1% boredom. But over the years, it tends to equilibrate somewhat the other way. But I must say that I've always found anesthesia to be very exciting. As I told you, it wasn't my first choice, but certainly as soon as I got into anesthesia, I didn't move after that. For me, it's been a wonderful specialty.
Do you ever feel pressure now? I'm sure you did in the beginning, but do you ever feel kind of nervous and kind of apprehensive?
I always feel a certain degree of nervousness. You're never quite sure what's around the next corner. That's why you must always be checking. You must always be aware of what's going on. And as I said, every patient is different. We must make sure that what are we doing is best in the interests of this patient, and always be aware and listening to what the patient has to say. I believe that patients are, for the most part, tremendous historians. They know what happened to them before, and anything they say to me, there has to be some importance put on it.
Mm-hmm. And it all figures into how you put that patient to sleep.
How you wake them up.
Now that's my next point. That's what I was going to get to, and you mentioned this on the phone when we were talking. You can put the patient to sleep, but waking them up is another story. Tell me a bit about that.
When we put a patient to sleep, what we do is we give them usually a dose of sodium pentothal or propofol as one of our newer agents, and we know reliably that 100% of patients with these drugs will go to sleep in a matter of about 30 seconds to a minute. We know that because these are proven drugs, particularly sodium thiopental has been with us for 50 years. We know it's a reliable drug. All these patients will go to sleep.
Now that is not the truth serum. People
No, it is
confuse
not.
it, don't they?
No, that's true. I can say that in my 30 years of anesthesia with sodium thiopental, nobody has said anything to me that they would not otherwise have said to me. Sodium amytal is the one that's used as a truth serum, but unfortunately the media doesn't always get those drugs straight.
We try to clear things up here on
I
cross-section.
appreciate that. Now, the problem is once we have the patient to sleep, how long does the surgeon need? What are going to be the fluid changes in the body? Is he going to lose a lot of blood? Not too much blood? What is this patient's cardiac function, their heart function, their lung function? How good are their kidneys? Are they able to metabolize the drugs that we're giving them? How is their liver? Can that metabolize the drugs that we're giving them? Their lungs, do they smoke? Has that caused any lung damage? Is it going to be more difficult to get rid of the drugs that we have given to these patients? What is the body weight of these patients? What is the difference between their fat mass, for instance, and their muscle mass? What is the metabolism, again, of the entire body? How difficult is it going to be, or how easy? When are we going to judge time to wake this patient up? Well, obviously you don't want the patient awake before the surgeon has finished, but at the same time...
Has anything like that ever happened to you?
To me?
Yeah.
I can't recall a patient actually waking up and the surgeon hasn't finished yet, because we do have drugs that we can quickly, when we reckon that the patient is beginning to wake up ever so slightly, because we're getting the blood pressure going up, the pulse is going up, and we monitor all these things all the time. Sometimes you can get the idea that maybe this patient is getting a little bit lighter, so we can give them a short-acting drug that will take them back down again for just a short period of time. Of course, you know, there are instances when patients have said, I remembered what was going on in the operation. Sometimes that is because the patient has been so critically ill. It's been important to give just enough anesthesia, not enough to have them completely unconscious, because we didn't want to depress their heart or lungs. These patients will frequently have some memory of what went on, but it is unusual for them actually to remember or to experience pain.
Let's get back to bringing them out now, bringing
Yes.
them to. How's that done?
How do we reverse the anesthetic at the end? Many of our agents today, for instance, isoflurane, and the new agent that's just come out, desflurane, these are gas agents, and they're blown out of the lungs, and they're usually blown out in a matter of about 5 to 10 minutes. So as soon as we turn it off, in about 5 to 10 minutes, the patient will wake up again. We have another intravenous agent called propofol, and that agent, too, is usually completely has completely disappeared in a matter of about 5 minutes or 10 minutes. Again, the patient will wake up. If the patient has been paralyzed because of a muscle relaxant, then we can give a reversal agent. And again, this should reverse the effects of the muscle relaxant, and the patient will begin to move again appropriately, and particularly to breathe appropriately. Of course, very occasionally we'll meet somebody who is a farmer perhaps, who has worked with pesticides, insecticides. These agents can get into the body and can destroy some of the substances that are within the body which are used to metabolize some of our drugs. So again, that can interfere with our ability to reverse the effects of some of our drugs. If a patient has been given a narcotic, we have a specific antagonist for that drug as well, called naloxone. We give that and we can reverse the effects of our narcotics, and again have our patient pretty well awake pretty quickly. We like to try and coincide the waking up of our patient with the end of the surgery.
Okay, you brought some equipment with you.
Yes,
Would you
I
like
did.
to demonstrate it for us?
Yes, I will. The equipment I brought with me is new, and this is some of the new equipment that has come in to demonstrate the safety of anesthesia. And what I'm going to do is, first of all, show you this pulse oximeter. I'm going to take your finger here, and as you see, this is nothing more than a non-invasive Band-Aid. We wrap it around the tip of your finger like this. And what this is going to tell us is the saturation of the blood in your finger, the oxygen saturation. And if we can see here, we have a little red line going up and down, and it's telling me that your oxygen saturation in your finger is 99%. You have a pulse rate here of 85, 86. This is very good, completely within normal limits.
Well, I'm still alive. That's comforting.
You're certainly still alive. I can see it. It's doubly proven to me, first of all, with a good oxygen saturation and with a pulse rate. Now, throughout the anesthetic, we will be watching this monitor very carefully. You know, up to 100%, it's time to sell. This is, we will monitor this from before we put you to sleep until after you're awakened and through your period in the post-anesthetic care unit. Now, this is telling me that there's good oxygen exchange across your lungs, that you're getting oxygen in, it's going across your lungs, it's going down to your finger, and with that I'm assuming that all the rest of your body, particularly your brain, is adequately oxygenated.
People would refute that, but we'll go with it.
Well, believe me, I'm a doctor. Now, should something happen that this pulse oximeter should become detached, for instance, or should there suddenly be difficulty with oxygen getting across your lungs for whatever reason, should your heart start to fail so that the heart is no longer pumping blood to your lungs?
I just died.
You just died.
Oh, God. Well, that's
No.
what you get for not having insurance.
That's right. What happens is now you see the oxygen saturation is falling rapidly. There's an alarm going off. We're in trouble. The anesthesiologist, in fact, everybody is now looking up at the machine saying, what's going wrong? What's happening? Let's do something right away. Let's turn that noise off. So this gives us an alarm which will sound within a matter of a very few seconds to tell us that there's something wrong with the equipment, with your lungs, with your heart. Something has gone wrong, and the machine is saying, pay attention to me now. Now, the other monitor that I want to show you is what's called a capnograph.
Okay.
Now, what the capnograph
The glasses
does...
come off for this.
Yes, because you're going to breathe in and out of this mask.
Right.
What the capnograph is going to tell me is how much carbon dioxide is coming out of your body. And this is telling me that your lungs are working, and this is telling me that your body is metabolizing. Now, if you just breathe in and out for me, breathe deeply in and out, and we see a green line going across here. Just breathe normally in and out. Just normally in and out. And as we see, we have this, this should go off in a second. Now we have this line going across. Your end-tidal carbon dioxide is 38. That is normal. That's telling me that you're metabolizing well. Carbon dioxide is getting out of your body, that you are breathing. That's the important factor. If we had the endotracheal tube in going into your trachea, this would be connected to the capnograph that we have here. We would see that carbon dioxide was being produced, and we would know that the endotracheal tube was properly placed. Now let's say, for instance, I'm going to take the mask back off your face again, put your glasses back on. Let's say, for instance, now that this comes off, that for some reason or other the tube is no longer in your lungs, that you have stopped breathing, that there's no more carbon dioxide coming off. What happens now is we no longer see that green light going across the line here. We see that carbon dioxide is reading 0, and again we have this alarm going off. This alarm is saying, pay attention to me now, there's something going wrong, there's no carbon dioxide coming out of this patient, pay attention, do something, find out what's happening. Again, this is a monitor, this capnograph is a monitor which is required equipment now in all operating rooms in the state of New York, and in fact almost throughout all of the United States at this time. But here in New York State it is required, both the pulse oximeter, the top one here, and the capnograph here. These are both required pieces of equipment, and these will tell me you're adequately oxygenated, that you are breathing well, good carbon dioxide coming out of your body. And with the use of these two pieces of equipment combined with continuous monitoring of your electrocardiogram, combined with frequent monitoring, and by frequent I mean every 3 minutes at least, of your blood pressure, by careful observation on the part of the anesthesiologist, we have made anesthesia today a very, very safe undertaking. And you talked to me earlier about the very nervous, very apprehensive patient. Yes, but I've taken these monitors to show to the patients. I've explained to them what I'm going to do. I'm going to be there with them, going to be taking care of them. For the most part, that will work very well. After that, then I might want to resort to using a little pharmacology, a little bit diazepam, and between the personal assurance, talking to the patients, a little bit of an anxiolytic, most patients nowadays, I think, at least can be modified somewhat in their anxiety towards anesthesia.
Would you talk for a moment about pediatric anesthesia? Is it difficult working with children?
Pediatric anesthesia does, of course, present special problems, special challenges. And within anesthesia today, many people specialize. And we do have pediatric anesthesiologists, just the same as we have obstetrical anesthesiologists, and anesthesiologists who are particularly interested only in neurosurgical cases. The pediatric anesthesiologist frequently has spent 6 months or a year in a specialized area just taking care of small children and the problems that go along with them. Pediatric anesthesia is, as I said, very challenging. It does come with its unique problems. Most of them, I believe, are addressed by these specialists within our specialty. One of the interesting challenges of pediatric anesthesia is, of course, it's frequently an ambulatory situation. We don't have the opportunity often of seeing the child before the morning when they come to us. And what our main objects are is to get this child safely, atraumatically, through the procedure and home again just as quickly as possible and back to playing with his or her friends again.
I understand you even have scented or flavored masks?
We certainly do. We let the child pick what flavor they would like. Would they like a banana one? Would they like a raspberry one or a grape one? They can breathe through the mask of their choice. Also, at the county center here, we can allow parents, as they wish, to come into the operating room with the child in a special program that we have. If the child would feel happier with his or her mom or dad coming into the operating room until the child goes to sleep, that's fine too. They're welcome to do that. At the end of the procedure, as soon as the child wakes up, there's mom and dad waiting for them in the post-anesthetic care unit to take care of them again. We have coloring books, we have all sorts of graphic aids like that to help the child before they come into the hospital, to explain to them what's going to happen and because I think one of the most important things is letting the child join in as much as possible in the decision making. How do you want to go to sleep? I found some children who would say, yes, I want to breathe in the mask. Other children have said, I'd rather have a little needle stick. And as much as possible, if the child is, shall we say, over the age of about 4 or 5, I'll explain to the child what I'm going to do and let them at least have some input into how we're going to handle them.
Dr. Frost, we have come to the end of this half hour. It has been most enlightening, and we hope here on Cross Section that we've quelled a few fears. You don't have to be afraid. People like Dr. Frost know what they're doing, and they'll put you down and get you up as quickly and as effortlessly as possible. I know that this will be enjoyed by many of our viewers, and I appreciate you coming on Cross Section with us. Thank you so much for taking time out.
Thank you.
Paul Rutkowski for Cross Section. Feel good. Feel good about yourself, and feel good about your anesthesiologist, okay? We've come a long way in this profession. Take care. Stay well. And if you should ever need some assistance of an anesthesia variety, well, just have confidence. Have a good week. See you next time.